Good evening, sir. Good evening.
Hello, sir.
Good evening, Zain.
Hi,
Hello,
sir.
Zain.
Hi, hi.
Zain, Chand Mubarak.
Thank you.
Eid Mubarak. Yes.
Thank you.
Very good.
कल ईद है आज चांद में.
हाँ, कल ईद है. अच्छा, my two colleagues have joined already, Sonali and Sahil.
I can't see them. Oh, there is Sahil.
Hello, good evening.
Hello, Sahil. Welcome to the program.
Thank you so much.
Vavikar sir, these are two young engineering college students from KLE Belgaum. They are in process of helping me develop part of the software. So, you know, the automatic recognition of the talus images, like what 4CDs does. So they are helping me do that. We've probably completed about 40-50% of that, and hopefully they'll help me do the remaining 50% as well.
Wow, that's nice, sir.
So they are 8th semester students, but they are open to taking up any kind of customized software projects and all. You know, if you or anyone else interested in, they are pretty good at what they do.
Okay. Definitely. Later on, you send their contact details to me.
Yeah. So today, when I'll be showing the software, also they are based on the suggestions. Last time I had made a lot of changes. So we'll see now whether it's more usable than before.
Yes. And actually, now what you do is that you, if it is usable, you start sending it.
Yeah. So after this webinar, I'll be sending it to everyone. And but still, there will be a version 3 which will come, which will be like completely integrated with these people's software. So,
yeah. See, if you are comfortable, you send. If you are not, then I'll wait.
No, but I am going to send now. I was not comfortable after the last webinar because there were a lot of changes. I realized it is very complicated. If not done correctly, it can lead to some kind of errors and all. So I thought better to wait.
Agree with you. That's nice. So he is Sahil.
Yes.
And
another person, Sonali. Welcome, Sonali.
Yes, sir. Thank you, sir. There was some issue, so I had to join late. Sorry.
Achha. Okay.
Nice.
Right.
So how many people are expected, Zain?
Sir, I have personally messaged everyone on the group. Everyone has said that they will join. Neeta Shah ma'am said that she will join a little later, maybe post 9:15 or so. But otherwise, everyone said that they will join. Probably another 5-7 minutes we'll wait, and I'll start introducing at least after that the concepts and all.
Fine.
Sandeep sir, the recording is
on
working.
cloud.
No? Okay.
It depends on how long you speak and how. I think I've got about 1.5 GB on cloud.
That should be enough. That should be enough for this meeting.
Typically, 40 minutes meeting will take around 90 to 100 MB.
Then that's a lot of GB then.
No, but now there will be some videos, maybe something. So
Not 90, not 90, 30 minutes, 40 minutes. 40 minutes will take, but 1.5 is quite a lot. Most important thing is that you download it within 2 days and keep it with you, because the moment you delete your account, the thing goes. And it is, it is not easy to access for outsiders, for others.
So Ronak and Sonal have joined.
Hi Ronak. Hello Sonal ma'am. We'll just start in a few minutes time.
Hi Zain, hi everyone.
Hey,
Hello.
Jay.
Hi sir. How are you sir?
अरे
Long
एकदम
time,
फर्स्ट
sir.
क्लास. तेरा
How
क्रिकेट
is
कैसा
it?
चल रहा है?
All good sir. Awesome.
Every morning.
Every morning, yes. Every morning.
Very good. So Vavi begins the day by playing cricket in the morning.
Wow.
Every day, 7 to 9.
Wow, fantastic.
So you do nets, or you play matches every day?
Matches are every Sunday. That is the reason why I couldn't come to the thing on Sunday. But every Tuesday to Saturday we have nets, and on Sundays we have matches.
Nice.
Hi sir, how are you sir?
Hi. Dr. Nagakar, we didn't meet you yesterday. Jay was.
I was just asking that only.
What is that?
Sir, आप नहीं आए थे sir कल.
नहीं मैं नहीं आया. But I am not a part of anything.
अरे
Sir थे आप sir.
How?
your
Sir
name
आपका
is
नाम है sir.
But nobody informed me.
Okay.
कल
Did you
पूना
get-
आइकॉन मीटिंग था, I think.
Were you informed that you are a part of a something committee?
Yes.
How you got informed?
I got an email.
No, I was not told anything.
सर आप कौन से कमिटी में हो वो मैं आपको लिस्ट आपको भेजता हूँ सर मैं.
अरे आज सुबह मेरे को आया कि ये कमिटी में तुम हो करके on a
अच्छा.
WhatsApp group that was formed.
Okay.
But earlier I had no this idea at all that I am a part of any meeting or any committee.
Okay.
Some inauguration committee I got to know. So I'll contact those people and find out. Welcome Nitin. How are you? Nitin Redia, I can't see you.
You can see name.
Sir, I think we'll start.
Yeah,
And
Janvi
more
has
people.
come. Hi Janvi.
Then we can wait till 21:10. 4 minutes. We can wait.
4 minutes more. Okay.
It's only 9:06. We can wait for
Okay.
4 minutes more.
Okay.
So it's good if people are there from the beginning.
Yeah.
Hi Nitin.
Hi, I'm just trying to. Can you see me?
No, I can't see you. I can hear you.
Okay. Yeah. Just moment.
Hello, sir.
Hi, how are you?
Good. All good. Hi, Priyanka.
So Sahil, which institution are you from?
I'm from Keli Dr. MS Sheshgiri College. So it's in Belgaum. So, sorry?
Oh, in Belgaum. Okay.
Yes. So the university that I come under is VTU. Yeah. So like I'll be passing out my I'll be a graduate in another few months. It'll be around August to September.
Wow.
Yeah. And so like we are from a computer science background.
I see.
Yeah. So like we have been doing many projects, and this is one of the projects which we have worked on, and we have enjoyed it a lot. So like
Very good.
yeah.
So these guys are very enterprising, I mean, these young engineering students who have to keep doing projects for their thesis and for their completion purpose, and they have guides who help them. And people like us, we can get a lot of benefit from guys like these, because there's so many things which we have in our mind, okay, we want this, and these guys are capable of implementing it. So they'll show a little bit of a demo of, how they have worked on my software. It's very good. I mean, and they're looking for projects. So
Hi, Janvi.
Hello, sir. How are you? Nice
I'm
to see you
great.
again.
Hooray, what a pleasure. How's your little one doing?
Little one's good. She's great, and another little one's on the way.
Wow,
Oh,
fantastic.
congrats.
Congratulations.
Congrats.
Thank you so much. Thank you so much. Hi, sir. Hi, Vavikar, sir. How are you?
I'm fine, thanks. Nice to see you.
Yes, nice to see you too, sir. Hi, Zain.
Hi.
उस दिन गाड़ी मिले थे ना इधर
The pair must be about
Dr. Aldevarkar's daughter's wedding.
Yes.
We had
Dad
a-
must have met all.
We had a nice time. Yeah, we met after such a long time.
Yeah, absolutely. I think the first time after the whole lockdown process, you guys must have met.
Yeah.
Where had I been, Ravi?
You came late, na, that day. Dr. Chamika's wedding.
Oh, yeah.
You got stuck in the traffic.
Of course. I met him there also. Yes.
You met him there, Raja. I left.
Okay, it's 9:10. I think. So shall we start?
Yes.
I can see
When
even
is-
Pavitra has joined. I think there are a fair number of people. We'll start and then the others can join later. Sandeep sir, that's fine, no?
Absolutely. I can keep on adding people as and when necessary.
So my screen is visible, right?
No,
Yes, I can see.
Yes, it is visible.
It's visible.
Visible, na?
no, I don't know why I can't see. I have a problem.
I can see.
Sandeep sir, let me know when you are ready.
I don't know why. I think my Zoom has stopped responding. I don't know why.
But you are the host, so it's important that your Zoom works.
My screen is not working.
Probably you have to check in your settings and see if.
No, I've allowed multiple people to. It happened when I closed that the participant screen, because I said, let me see a better view. And now it's not responding.
Should I start?
Maybe you can log in from the phone.
Should I'll stop this screen share and start it again. Should I do that?
No, I think we have.
Zain, I think that would help.
What?
Try it out. No? I think that would help. Resharing your screen.
Now is my screen visible?
Yes.
Can't hear anything from Sandeep sir. He's there or he's.
I don't think it's there. Let's wait
He
for.
left, I think. We'll wait for him.
Wait for him to join.
I have admitted Nitin Dedia again.
Vavikar sir, you are also the host now, right?
I don't know.
He's made you the host.
he's the host.
Fine. As soon as I get any notification, I'll ensure that that person joins. Yeah, host. Yes.
Nagvikar sir has left. We'll wait for him to join. Till Nagvikar sir joins, I'll just give a brief overview of what we had discussed last time to other people who hadn't attended last meeting.
I think
So
Zain,
basically, yes, sir.
I think wait now, because
Okay.
it is important that Dr. Nagar also gets
Uh-huh.
in from the beginning.
Okay.
He is joining now.
Okay.
Dr. Nagwekar, I will unmute you. Oh, now I'm not the host.
Zain, can you hear me?
Yes, sir.
We can hear you and we can see
I
you.
think we are all okay now.
Can you see my screen?
Yeah, you,
I can
you
see
can
your screen
start
also.
now, Zain.
Okay. Perfect. Okay. Okay, I'll start now. Thank you everyone for joining. It's really, I consider it as an honor that everyone is removing their time from their schedule and listening to me talk. Uh, it's not, for just, I just don't want to promote my software or something like that. But there are certain things which I feel, is very important to discuss related to Contoura LASIK, or technology which is not fully understood, and in fact needs to be fully understood. And I feel that, whatever opinions and knowledge I have learned related to this is something that I would like to at least share with my fellow doctors and seniors, and take their feedback and opinion on these concepts. So I have designed this presentation in such a way that, I discuss some of my interesting cases and take feedback, and at the same time explain how my software benefits in doing this. So okay, so first question that needs to be asked is, why do all of y'all need to learn about my software? Like, is it for my benefit, or is it just something that needs to be understood? So I'm not just explaining this for my benefit, but actually to discuss about this technology. So Contoura LASIK is a beautiful technology, but it is very rarely understood, and it can be done using the protocols which Alcon has given out to us, but according to me, if you only do Contoura LASIK using the protocols that Alcon has given out to us, you will very rarely experience the advantages of Contoura, and over a period of time, you will realize that your wavefront optimized is giving you equally good results, which is actually not the case. And also, there are many times cases when you feel that, should I do or should I not do Contoura for this? But if you understand what I'm going to discuss today, you can be very confident to do Contoura for any case. However, the topography is, obviously considering that the patient is eligible for the procedure, but you can do Contoura without having to think, you have to do wavefront optimized. So just to kickstart this discussion, I would say that out of all the patients we see for LASIK, you can categorize the patients into three groups. The first group is those in whom the topography, anterior corneal topography cylinder, matches very well with the manifest cylinder, as can be seen here. And this, I would say, comprises about 50% of the patients. Then you have the second group, where the topography and manifest cylinder may not be similar in magnitude, but the axis is very similar. And I would say in this group, this constitutes about 30% of the patients. So these two are 80%. And then you have the third group, in which the topography, cylinder, axis, and magnitude both are extremely different from each other. And these are generally patients who have higher, higher order aberrations on the cornea. And I would say these are about 20% of the patients. So if you see what is the actual benefit of Contoura, the group 1 in which the topo and manifest cylinder are very close, I would say there is no real benefit over wavefront optimized. And these are the patients that were included in the FDA study. So you will realize that, yeah, my Contoura results are very good in these patients, but you'll also get equally good results with wavefront optimized because wavefront optimized is so good. In the second group, you can say that Contoura does benefit over wavefront optimized in some cases, but it can act as a double-edged sword, meaning in other cases, you'll realize that wavefront optimized would have given better results as compared to Contoura. And the third group, in which the topo and manifest cylinder axis both are very different from each other, I would say this is the group which gives maximum benefit from Contoura because they have higher aberrations. But all the softwares, at least Alcon software will tell you that you should not do Contoura. It is not recommended to Contoura. You don't get confidence to do Contoura. So then you are realizing that you're not actually benefiting with Contoura because in the cases in which you're getting good results with Contoura, you're getting equally good results with VFO. And in fact, in some cases of Contoura, you're getting even worse results. So I would say that you need some kind of software guidance to tell you about how you can do Contoura in all these cases, including group 3, which give us the maximum benefit. Softwares like 4CDs and my iSMART software, these you can do group 2 cases with certainty that you're doing it correctly, and you can also do it in group 3 cases very safely. So this is the advantage of using these softwares for Contoura. You are actually getting the benefit of Contoura. As far as the 4CDs is concerned, it is not available anymore for use in India. I don't know if anyone has got it besides the initial few surgeons who are using it, but I don't think he's handing it out to anyone else. And the second very important thing is you need a Pentacam, Oculizer, Galili, these machines for using this software. So if you don't have this, if you just have anterior corneal topographer, you cannot use this software. So these are the disadvantages of 4CDs, and this is why I felt I needed to make my software. So let me explain how does this software, either 4CDs or iSMART, how can it help to plan Contoura cases? For this, let us understand the basics. If you see, what exactly is the manifest cylinder which you accept on refraction, in this case minus 1.75 at 60, what is it made up of? It is made up of cylinder coming from various parts of the eye. So the first is the anterior corneal cylinder. Okay, so this value, which is the measured value, is the anterior corneal cylinder. This is one of the components of astigmatism. So when you keep your modified refraction at 0, you get this ablation map, as we've all seen in the Contoura. This is the higher order aberration map. Now, this higher order aberration also induces some amount of astigmatism, which is also coming from the anterior cornea. So this also contributes to astigmatism. Then comes your posterior cornea, which is also contributing to astigmatism. And finally, your lens, the internal or lenticular astigmatism. So in short, this manifest astigmatism, what you are accepting at the spectacle plane, is a vector addition of the anterior corneal cylinder, the higher order aberration astigmatism, the posterior corneal astigmatism, and the lenticular astigmatism. Now we know these values, which is the manifest astigmatism. We know the anterior corneal astigmatism. We can find out the posterior corneal astigmatism. So if we have a software which will tell us what exactly is this higher order aberration astigmatism, then we'll just have one component which is left. So by vector mathematics, we can find out then what is the lenticular astigmatism. And once we have the individual components, we can see how all the components are affecting the manifest astigmatism and not only the anterior corneal topography, which is given by the topolyzer machine. So this way, we can safely do Contoura in all cases in which the manifest and the topography cylinder are different from each other. So am I clear up till now? If anyone has any doubts, you can ask me. Should I go ahead?
So Zain, you would need either an OPD scan or an eye trace, right? To get this lenticular, to get the total astigmatism.
So basically, the software, my software itself is going to calculate the lenticular astigmatism because it has all the other components. So when you have in a mathematical equation, when you have all components and you have to find the missing one, you can just use the substitute that and get that particular thing. So what 4CDs does, what my software is also doing, is it is calculating the lenticular astigmatism from all the other values which are there, from the manifest astigmatism, from the anterior cornea, from the posterior cornea, and the higher order aberration astigmatism, which the software, I will show how it calculates.
I just wanted to ask something. Can I?
Yeah, please.
Suppose we do the LASIK now, and after 25 years, the patient has his lens change. What kind of impact will it have then?
So, Dr. Jay, when we are doing a wavefront optimized treatment, we are anyways accounting for that lenticular astigmatism, right?
Okay.
Because we are correcting the overall astigmatism, we are correcting the overall refraction, which includes components from everything. Many times we see the corneal topography doesn't match with the manifest. So obviously the lens is playing a role. But when we are doing wavefront optimized, we are correcting everything. We are not correcting only anterior cornea.
True.
So basically how the lens will behave later, we don't know. But we still need to account for the lens when we are doing Contoura, because when we are doing Contoura, we are correcting the we are supposed to be correcting the anterior corneal cylinder on the cornea, but you cannot just account for that ignoring everything else, especially in cases in which it is different from the manifest.
True.
If you just do it without lenticular astigmatism, if your lenticular astigmatism is not much, maybe the patient will be able to adjust later and he will. But suppose you have high lenticular astigmatism, then that patient will not benefit if you are correcting the anterior corneal topography.
Zain, can I ask a question?
Yes, sir, please.
So 2 questions here. Which is the most reliable instrument for measuring the posterior corneal astigmatism for your software? That's number 1. And number 2, lenticular astigmatism, ever since this OCRST and other instruments have come, show that a lot of your lenticular astigmatism is compensating for the corneal astigmatism.
Yeah, that's right, sir. It is contributing. That is why.
So it seems to be a very dynamic thing which goes on and which changes with time. As we know that once the patient develops sclerosis, is against the rule, lenticular astigmatism increases. So if you can briefly touch both these questions, first starting with the posterior corneal astigmatism.
So see, as far as posterior cornea is concerned, I think Vavikar sir and Neeta Shah ma'am would be in a better position to comment, because they've been putting the posterior corneal astigmatism in 4CD software and using it since quite a while. I don't have a device which can accurately measure posterior cornea. That is why my software has a nomogram which I use, which I'll be showing, which works very well according to me.
So that nomogram is something similar to what Barrett uses in his IOL.
It's based on Barrett's nomogram for toric IOLs.
Does your software give the option to input the posterior corneal?
Yes, it gives an option to input, or it gives an option to put in your own, or it gives an option to not consider. All 3 are there.
Okay.
So I would say I would like Vavikar sir to speak on this, because he's been doing it. But from what I have heard, the posterior corneal astigmatism from the Pentacam or from IOL Master 700 both are equally accurate. And I think Neeta Shah ma'am has done a study to prove that both are equally accurate, which you can put into the. But Vavikar sir or if Neeta Shah ma'am is there, you all can just briefly speak on that.
Yes, absolutely. See, our toric calculator, Vavikar Saurabh toric tool, was based upon 1,600 cases of Pentacam virgin corneas. And what we realized that we came to the same conclusion as Barrett. So posterior corneal astigmatism, if you measure by Pentacam, it is fairly reliable. Now that I have got MS39 and IOL Master 700, it does not vary much. In case of cataract, when the level is really finer, it probably matters. But for LASIK, you use it from any source, IOL Master 700, Pentacam, or any other MS39, it should be okay.
Okay, Nagvekar sir, about your second question, absolutely right. Lenticular astigmatism is very dynamic. That's why in 4CDs as well as in my software, we never correct the entire lenticular astigmatism. So what Dr. Lobinov has said, that if you correct half the magnitude of lenticular astigmatism and leave half of it behind, that much is enough to compensate that the patient can relax the remaining lenticular astigmatism. And that is what he has done in 4CDs. That is what I have also done in my software. And it works very well. So you don't take the entire, you take half of it in magnitude.
Correct. Okay. So the algorithm that you have developed is already accounting for posterior corneal by assumption. So there's lenticular astigmatism is also by assumption.
Lenticular astigmatism is calculated. It's not assumed. Yeah, it is assumed based on the calculation. It's not because there is no machine right now which can accurately measure lenticular. Even your eye trace, if you do it some 3-4 times, it will give you different lenticular astigmatisms. But in essence, if you want me to explain, if you see a patient in which the topography is different from the manifest cylinder by a great amount, either in axis or magnitude, whenever you put this patient on an eye trace, you will see that the lenticular astigmatism is high. How high? What is the magnitude? What is the axis? For that, you need vector mathematics. So that is what 4CDs does. That is what my calculator does. You need a vector mathematics to know what is a lenticular astigmatism, because all these are vectors.
Yeah. So after having measured the anterior corneal topography as well as the higher order aberration from the Vario machine, you have a nomogram to tell you what the posterior corneal astigmatism would be. And then looking at the manifest astigmatism, you calculate the lenticular astigmatism. Exactly, and you input half of that value with the vector provided by the software, correct?
The software itself does it. So the software adds the lenticular astigmatism, it adds the anterior corneal topography, and it adds the higher order aberration and posterior cornea to give you a final vector. So there are 2 steps of vector calculation. The first step is when you're getting the lens. Second step is when you're doing the final refraction, considering all these things.
I think if it's clear for everybody, you can proceed.
So just coming back to this, so one thing what I want to emphasize is, in order to get an accurate lenticular astigmatism, since all the other values we have got, we need to accurately measure the higher order aberration induced astigmatism. So this is what the calculator has to do. This higher order aberration has to be done, and this is also called as talus astigmatism. The word talus given by Dr. Lobinov. Talus refers to the higher order aberration profile. You see the peripheral purple ablation zones, which you can see 3 zones over here, which are causing a kind of a trefoil kind of pattern. So these 3 are called as 3 taluses, and each of them induce some amount of astigmatism. The total astigmatism induced by all 3 is what we call as the talus astigmatism or higher order aberration induced astigmatism. Now, the 4CD software does this automatically. You have to import this image into the 4CD software and you get what is the talus astigmatism. In my software, currently the version 2 of my iSMART software, this is the manual part, meaning this is what we have to do by ourselves. And this is what I'm going to teach you before I hand out the software to others, that how you identify these taluses and get the astigmatism. Now, last time when I had taken the webinar, it seemed to me that people were having difficulty in understanding this. But now I've tried to simplify it. I've made a lot of changes. And I think it is not difficult once you do 2-3 cases. And when I show my case examples, I'll show you why it is important that you do this and then you do Contoura. So if you just see what is written here, each talus has to be identified in terms of 3 things: angle, color, and its horizontal size. And once you feed this into the software, you will get the talus astigmatism. So I'll just give you an example of how this is done. So this is the sheet what we get on the planning PC. We've kept our modified refraction at 0, and this here down is the ablation profile. Now, first step is I need to mark out what are the taluses over here. Okay, now this I'm just going to be telling you how I do it. So I'm just marking the taluses. This is 1 talus roughly. This is a 2nd talus, and this is a 3rd talus. So these are 3 taluses that I have marked out. Now the second step is I need to get the angle of each of these taluses. please stop me if someone wants to interrupt and ask some question, because I'm just going to continue speaking. So I need to find out the angle each of these taluses makes with the center. For this angle, we need to see what is the central point of the talus. So with a star, I have marked the central point of the 3 taluses. Of course, when you do this, this all has to be done in your mind. You're not going to actually mark it, but centrally, roughly the central point of the 3 taluses. Now, what angle this central point of the talus is making with the center is what we have to do. For the angle, we've got these grid lines. So every ablation will show these grid lines. These grid lines are nothing but 30-degree apart lines for the angle. So if I just enlarge this image, I'll just show you what are the angles of the grid lines which are there. So you can see, if you start from the right hand side, you've got 0, 30, 60, 90, 120, 150, 180, and again go back to 30, 60, 90, 120, 150. Now this reference of the angles numbered is not actually shown in the the Alcon planning sheet, but I've put a reference diagram like this in my software, which I'll be showing you. Now, how much angle each of these taluses is making, we can understand by this reference. So if you look at the first talus here, it is the central point is between 0 to 30 degrees. So this talus angle is at 15 degrees. The second talus, if you can see, is between 120 to 150. So is somewhere 135 degrees. So the angle of the second talus is 135 degrees. And the third talus you can see is between 60 to 90, somewhere in the center. So you can mark it as 75 degrees. So we've got the angle of the 3 taluses here, 15 degrees, 135 degrees, and 75 degrees. Are we clear? Should I go ahead?
Yes.
Yeah.
Okay. Second step is now, okay, this is the angle. Second step now is to identify the color of the taluses, which you have to feed into the software. So for color, in my software, I've put this talus color zone reference. So you've got these references of the colors of the taluses. You just have to feel what color is there, and you have to put the zone accordingly. So bright purple will be zone 1. If it's normal purple, zone 2, dull purple, zone 3, dull red, zone 4. And you can do this just by your assumption, what you feel. It doesn't have to always be 100% accurate. Like if you go from a zone 2 to zone 3 or a zone 2 to zone 1, won't make that much of a difference. It's just for your understanding. So if you look at the taluses here, we can see talus 1 is the brightest. So that will be zone 1. So you have to feed this as zone 1. Talus 2 and talus 3 both appear to be purple, and I would put them in zone 2. So we've got the color zones of the taluses, zone 1 and zone 2 and zone 2. The last thing that you have to identify of the talus is the horizontal size. Now, how long is this talus with respect to the grids that you have got? So just let me show you. So one grid would be the distance between any 2 grid lines. So this is one grid. This is one box or one grid, and 2 grids would be between 2 boxes. Are we clear? So this particular talus here is measuring so much in horizontal size, and you can see it's occupying little more than one box. It is little more than 1 box. So this is 1.5 boxes. The second talus is about 1 box, and the third talus is also about 1 box. Any confusion on this?
No.
Okay. So then once we've got this, then this is how you enter it in the software. Talus 1, angle 15 degrees, color zone 1, horizontal size would be 1.5 boxes. Talus 2, same how we discussed, 135, color zone 2 and 1 box. And talus 3 would be 75 degrees, color zone 2 and horizontal size is 1 box. So now once we've entered this, the rest of the thing the software does automatically. This is in the version 2 of my software. Currently, this is manual, but the engineering students who I'm going to collaborate with, they have a software which shows you can import the image how you do in 4CDs and get the automatic angles and color zones and everything. But we are working on that. That is not ready yet. But why it's important for each surgeon who is doing to also understand this concept and also know how much is each talus inducing, because many times an automatic software may not always be accurate, but what you manually see will never be inaccurate. So this is how we do the entry. And once I have explained this concept, now I'll go to showing how my software looks and how it works.
And one doubt,
Yes, sir.
distance from the center is not important.
No, it's not important.
Very good.
The reason why it is not important is, I'll show you. I think I discussed this last time also. So I am considering the horizontal size of the talus, right? So yeah. So if the horizontal size of the talus over here is one box, and if it is over here in the center one box, so they are both one box, but they will have different effects, right? A talus which is in the center, if it is longer in the center as compared to the periphery, it will have more effect. So when you feed in the horizontal size, you are actually already considering the distance from the center, because I am considering the horizontal size with respect to these number of boxes.
Okay.
So did you understand that?
Yes.
So that is why you don't need to mention the distance from the center. That is taken care by just mentioning the horizontal size in terms of the boxes. Okay. So now once this is understood, I'll just show how my software works. So my software basically is Microsoft Excel based software. What you're seeing now is the primary screen, and it not only helps in Contoura. So even if you are not doing Contoura, you're doing a basic LASIK wavefront optimized on some other machine also, it will give you all the basic safety parameters like ablation depth, residual stromal bed, percentage tissue altered. It will tell you whether LASIK is safe or no. It will do nomogram corrections. So you can choose the microkeratome from the two common ones, that is Moria SBK and Moria M. Yeah. And if you're doing femto, you can put in femto. So it will tell you what should be the proper size based on the white to white. And the microkeratome is also done in very great detail. Meaning for M2, it is done using the horizontal, it's done using the steep K and the white to white, whereas for SBK, it is done using the horizontal K and the white to white. So it is exactly as per the, the nomogram which is given to us by the company. So it will tell you the ring and stop size. So this is how the primary sheet looks like. I'll just show you when you feed in data for a case, how does the primary sheet look? So this is data which is fed in, you feed in the refraction, corneal topography, you feed in here. So this corneal topography, you can either feed it from your topolyzer, or if you have any other reliable topography machine like your pentacam or something, which, or even an autoref which you feel as a good keratometry, you can feed in that, because this is used for your microkeratome, and it will also be used as your alternate machine when you are doing Contoura planning. You can put in your thinnest pachymetry here. You can put in your mesopic pupil size, white to white, optic zone and flap thickness. You can see ablation depth, residual stromal bed, percentage tissue altered, microkeratome. And here in the comments box, you can see it's showing right eye and left eye both are safe for LASIK. Now, suppose if I change this refraction to minus 8.5 in the left eye, you can see now the message will come, left eye LASIK is unsafe, because the PTA has gone above 40. So 40 is the cutoff for PTA. It will tell you, yeah, you can reduce the optic zone. Now, if you reduce the optic zone also, if it comes back in the normal range, it will be safe. But again, a message will come that the pupil is large, try increasing the optic zone. So it covers all possible aspects of basic planning. Whatever is your, kind of refraction and all your parameters you've fed in, it will quickly tell you whether LASIK can be done or not. Okay. And now suppose you're doing only a wavefront optimized and you're not doing a Contoura. Right here down in this lower right hand side box, you will see that this is the final refraction, and you've got nomogram corrections which you can feed in. Now cylinder nomogram correction automatically comes here, but for sphere, you have to just click on this sphere button, and you'll see your right eye and left eye in this graph. So you can see the red dot is for right eye and the yellow dot is for left eye. Now yellow is coming in minus 0.25. So here you just click minus 0.25 and you go back to primary sheet. And now your wavefront optimized or custom Q final treatment based on the nomogram is here, which you can feed into the machine. And you can take a printout of this entire page. Okay. Now suppose you want to do a Contoura planning, then you have to click on either right eye Contoura planning, click here, left eye Contoura planning, click here. So I click on the right eye Contoura planning. Before I show you actual Contoura cases, I'll just give you an overview of how the Contoura pages look like. Okay, so this is the Contoura planning of the right eye. So if you can see here, you have to put in the measured topography, cylinder magnitude and axis over here. Your modified refraction 0, your ablation profile, meaning your higher order ablation central and maximum. The taluses, angle, color zone, horizontal size, how I showed you, you have to put in here. So color zone, you have options from 1 to 6. Horizontal size, you have these options, half box, 3/4 box, 1 box, 1.5, 2, whatever it is. And you also have also put in the reference diagrams right here next to it. So when you have the Contoura planning PC opened, you have your reference diagram. So you have a diagram for angle over here. You have a diagram for color zone reference, and you have a diagram for the talus box, the horizontal size as well. So you can refer this. And if you still have difficulty, if you click over here, you will get a full instruction manual on how to fill in the talus data. So this is incorporated into the software only. So everything what I discussed is in written format with examples over here. So if you ever have a problem, you can just refer to this, how to fill the talus data. And then you go click back to right eye over here and you come back to this page. So you feed in all this. Now down here, you have posterior corneal astigmatism. You can choose either do a manual entry, software inbuilt nomogram, or do not consider. Now in my initial software, I had a very big diagram to show the posterior corneal astigmatism, what to feed in. But in this, it's not like that. If you use software inbuilt nomogram, it will be done automatically. You don't have to feed anything at all. And this is how I do it. But suppose you have a Pentacam or IOL Master 700, you just do manual entry and you feed in the data here. So PCM magnitude, whatever is the magnitude, and what is the steep axis, you can feed in here. Okay. So once you do this, you press proceed. And now you get all the components shown here. So what is the total corneal astigmatism from anterior, posterior cornea? What is the talus astigmatism? What is the internal astigmatism? And then here you can choose whether you want to use the topolizer topography or alternate topography. I'll just show you here whether in an example how this works. And then you press proceed. And when you press proceed, you get what are the Alcon recommendations for this case? What is the iSMART software recommendation? And here, what is the final modified refraction which you have to enter? Over here on the right-hand side, you get what is the Contoura myopic overcorrection, meaning you will get what is the C4, C12 compensation happening in this case. And you can choose whether you want to include it or not. So if you want to include, you press include it or do not include. And then last is whether you want to include the sphere nomogram or you do not want to include the sphere nomogram. So ideally, you should keep this always included because that is how Contoura works best. Okay, so this was just a brief overview. Now, with this understanding, I hope everyone has understood the basic parts of the software. I'll go and show some 3 important cases, and each case will show you something significant. Should I go ahead, or if anyone has any questions, you can ask me?
I think you should go ahead.
Thank you, sir. So this is case 1. Okay, so case 1 seems a pretty straightforward case in which the topo cylinder and measured cylinder are quite close to each other. And you see modified, I've kept 0, and this is now the higher order ablation profile that is there. Nagvekar sir, how would you go about doing this for the final refraction? What would you do? This is a pure cylinder patient and
So
both match quite well.
correct. So basically first I'll go to 0, 0, 0.
Yeah, it is 0, 0, 0.
Yeah, as you are now. And I can see that the ablation in the periphery is about 11.04. In the center is about 4.24. So roughly about 7 micron extra tissue is there, in the periphery. So that would correspond to about half a diopter of correction. So I'll have to probably compensate by -half. And I would also look at the Zernicke for the C4, C12 compensation.
Okay. So unfortunately, this is a photo, so I can't open the Zernicke here.
Yeah.
But okay, so you would do C4, C12, but that C4, C12 is for the sphere. What would you correct for the cylinder in this patient?
For the cylinder, yeah. So
Okay.
normally in this, I think probably I would go ahead with what the measured cylinder is.
Okay, it's more or less pretty similar.
Yeah.
But you know what? There is one concept which, of course, my software utilizes. Whenever you see a ablation which happens along the horizontal meridian anytime, like in this case, when you've kept your modified refraction at 0 and there is a horizontal ablation, meaning without any correction at all, you're still ablating, you're still steepening the horizontal axis, which is the flat axis, right? The flat axis is the horizontal axis in this case. And without any correction also, you see, because of this talus over here, you are almost steepening 11 microns, which, as you said, comes to almost, I won't say half diopter, but little less than half diopter. So you have to compensate for this in your final refraction. If you still think of correcting.
That's what I said, no, minus half sphere, almost.
No, but in the cylinder also, this talus itself is going to cause some amount of cylinder. So you have to compensate such that this talus is taken care of in your final refraction, because the Alcon is not telling you how much this talus is affecting your refraction or your measured cylinder.
But correct me, I have probably not understood this correctly, but the talus represents that area of steepening, na, in the horizontal.
Right, it represents an area of steepening.
So when you flatten it, you are going to flatten the cylinder more.
You are going to steepen the horizontal axis.
How?
So the horizontal axis is what you want to steepen, right? Because the horizontal axis is flat.
Yes.
I would say meridian. The horizontal meridian is flat in this case, right? Minus 3 at 180 is with the rule astigmatism. That means the horizontal meridian is flat.
Yeah, and the vertical is steep.
Vertical is steep. Now with this ablation, which is in the periphery, without any correction, you are flattening it slightly. Okay. Sorry, you are steepening it slightly. Without any correction, you are steepening it slightly. Am I right?
No, there is some confusion. See, let us not get confused between axis and meridian. Talk only about axis.
Okay, so minus 3 at 180.
Correct.
Minus 3 at 180 is the flat axis is at 180. Am I right, sir?
Absolutely.
Okay. Now, when we see this talus over here, the central part of the talus is also at 180. Am I right?
Correct.
And this talus is peripheral steepening. It is steepening the 180 because it is at the periphery. Any time you do ablation at the periphery, it's steepening. So that means your minus 3 at 180 without any correction is getting steepened at 180 by 11 microns without putting any correction. Am I right, sir?
Now, when you show me this map, Zain, are you referring to the ablation pattern?
Yes, sir. I'm referring to the ablation pattern.
So, in other words, you are saying that by removing the higher order abrasions, you are going to steepen the horizontal meridian also.
Exactly. You are going to steepen the horizontal meridian, right?
Yeah. So the steepening is done by flattening the vertical meridian, correct?
Correct. But my point is not that. My point is the horizontal meridian is already getting steepened a certain amount in spite of keeping everything at 0. That means if you go ahead and correct your minus 3 at 180, you are going to slightly overcorrect, because in spite of there being 0 correction, there is still some amount of ablation happening. That means if you add 3 more to that, it will get added to this 11 microns. So that is why.
Can I just add a point?
Yeah, Rona.
I think what you're trying to say is, if this talus was not there, we needed to correct 3 at 180. Now, since there is a steepening over there, the correction should be ideally something like 2.9 at 180. Because already compensating a little over there without refractive correction.
Perfect. Exactly. That is absolutely what I'm trying to say. You have to reduce slightly, because this talus astigmatism is also contributing to your manifest refraction. From the slides which I had explained earlier, your -3 at 180 is also coming from this talus.
Then
That is why, yes, sir.
One a black and white answer. This is what we are seeing right now on your screen is what will be the effect of the ablation, or is it the ablation pattern? Because
it both mean the same thing, sir.
Sorry, just let me complete. Because this purple zone seen over there seems to indicate that this is where the ablation is going to take place.
Yes, sir. That is where the ablation is going to take place. That is
By
what it
ablation,
means.
you flatten, no? You don't steepen.
So whenever you have ablation taking place in the periphery, that ablation is going to steepen that place. It will not flatten that axis. It will steepen that axis. So that is why when you do a hypermetropic correction, you have a circular purple pattern at the periphery because the periphery is getting steepened.
No, periphery is getting fattened and the center,
center is getting steepened better.
No, sir. The mid periphery part of it, that part is getting steepened. I agree. But whenever when you have, what I'm trying to say is when you have a pure cylinder, whenever you have a pure cylinder correction or you have a hypermetropic correction, you always have ablation which is in the periphery and not in the center. So
say that again.
Okay, sir, you know what? Let me just explain this concept to you with another example. Okay, from one of the.
Can I ask you one question before that?
Yes, sir.
Now, for the time being, keep aside Contoura. Suppose this patient is for patient is of -3 at 180. Okay, you will see the ablation at 12 o'clock and 6 o'clock.
No.
3 o'clock and 9 o'clock.
3 o'clock and 9 o'clock, sir. I'll just show this to you with an example. I'll show it to you with another example.
What is talking?
This is the example that I'm showing you. Look at this particular case example. This is from one of the head. This is wavefront optimized treatment. This is -1.75 at 90. And you've got your ablation, which is at 90 only. So whenever this is wavefront optimized ablation, whenever you have a minus ablation, whenever you have a minus cylinder, means your minus cylinder axis, ablation will always be in the periphery in that axis because that is the flat axis and you want to steepen that axis. And the only way you will steepen it is by ablating at the periphery. This is what I'm trying to say.
And so therefore the mid periphery and center gets this steepened.
It gets steepened. Yeah, that is
now
what I'm saying.
Go back to the previous example. So over here, you are trying to say that out of -3, 0.5 is already treated by the HOA. So we have to treat only -2.5.
Exactly, but not 0.5. So that is exactly where the software works.
Correct.
Because
I'm just giving an example.
Right. Your example is correct, sir. So you need to undercorrect little bit to because if you consider all the factors, then because this ablation is in the periphery, exactly in the place where the flat axis is, that is why if you correct the same amount, you will be overcorrecting slightly.
So one concept which you are inculcating in us is that whenever you see there's ablation over there, adjacent to it, there will be steepening.
No. Yeah, yes.
In the same axis.
That same axis is getting steepened.
Yeah,
that is the flat axis, it is getting steepened.
By periphery, you're talking now, I can see from the zones, this is at around about around 6 or 7 millimeters. Between 6 and 6.5 millimeters.
Right, sir. Yes.
Okay.
Then just one doubt. So suppose if today you ablate this profile without any refractive, like it will go 11 microns at periphery and 4. And then, for example, hypothetically, 5 days later, you put in the value, the measured will come less and your refraction will come as 2.8. And that day you treat 2.8. So that is how what you're trying to say.
Exactly. That is, yeah, it is like that. It is definitely like that. And I have the case example ahead, which I have will also prove this point. And I'll prove it to you by showing you the actual numbers. That is why I've got wavefront optimized treatments ahead to show you how this concept works. So this concept is exactly what you said. So if you treat only this, After 5 days, if you do the refraction, it will not be 3 anymore. It will be lesser because you have already corrected some amount.
Yeah, excellent. Understood.
And this Alcon doesn't give us. So this Alcon doesn't tell us. Alcon doesn't tell us how the higher order aberration is actually affecting the refraction, the manifest refraction. This we are left to deduce by ourselves. So this is something that needs to be understood. Anyways, so just showing you this particular case, if you had to,
just a second. So just taking this ahead, if the software will help us calculate, so certain topo-guided treatments when you do for an irregular cornea, or a complicated cornea, I guess you can do it in a one step then?
Yeah, exactly. I do all in one step. I don't do 2-step at all.
All right, great.
Yeah, and I'll show you that my last example will show you how in one step you can do very irregular corneas also. I'll just show that. First step in this case is, I'll show you how I mark the talus. So this is the main talus here. So this is I'm marking. It's pretty straightforward. This angle is at 180. If you see the zone, this will be in zone 1 because it is bright purple. And if you see the size, this size is 2 boxes. Right? This is horizontal size is 2 boxes. It's occupying 2 boxes here. If you want, you can even consider these 2 small taluses, one here and one more here. These are red taluses, so their zones will be behind. These will be zone 4 and zone 3, and the angle of this would be, this would be at 120, and this would be at 60. But even if you don't consider these taluses, it's fine. It's not going to make a difference because they are so small. But I'll just show you this case. Okay, so this same case now I'll show you in my software. This right eye data has all been entered here. Now we go to right eye Contoura planning. We click here. So now I've entered the magnitude and the axis of the measured topography cylinder. I have entered the modified refraction 0 ablation profile 11 and 4, and I've entered my talus data over here from the 3 taluses that were there. I have written posterior corneal astigmatism, choose the software inbuilt nomogram. So I have not entered anything for PCA. I press proceed. Now you see, considering the posterior cornea, the total corneal astigmatism is already showing to be slightly less, minus 2.83. The talus astigmatism is showing you to be 0.29 at 175. The lenticular astigmatism. So to answer your question, Ronak, the lenticular astigmatism is calculated by vector mathematics. It also plays a role. So it will not be like, if you correct this completely, there will be, it will be absolutely black and white. So the lens will also play a role and compensate. So there is some amount of lenticular astigmatism also. So this page will show you how the 3 components are. Then here you can choose topolizer, or if you choose alternate, you can just have a look if it is very different or same. So when I choose alternate, it's becoming 2.69 at 176. So I'll stick with my topolizer because 2.83 is quite similar. And I'll press proceed. Now here it will tell you Alcon's recommendation is Contoura LASIK can be done. Soft recommendation is also that it can be done. And this will be your final modified refraction. 0.26 minus 2.76 at 1 degree. This is got using vector mathematics, and it considers the ablation profile and it considers the lenticular astigmatism. So it tells you that in this case, you have to undercorrect by 0.25.
Excellent.
And here it tells you that, yes, sir.
Can you remove those 2 minor taluses and we can see how much will be the difference?
Yes, sir. I'll do that. It's the same.
Very good. Excellent.
And I'll remove posterior cornea also and show you, sir. I'll remove posterior cornea. We'll see how much that plays a role. So do not consider. So there's a slight difference, but this difference is also not likely to be very significant. So it just shows why posterior cornea is not given that much importance also. Even if you feed in some other, random value, if you consider as manual entry,
But what do you recommend then? We should feed it in or
Yeah,
not?
so see, I have made this software keeping in mind the posterior cornea. So I would always use it. Now, if I would have a pentacam, I would always do it manually because pentacam PCA is very accurate and repeatable. So is IOL Master. But I don't have them, so I have not done it. And I've made this for myself. So that's why I'm pretty confident with my software inbuilt nomogram. But if you have pentacam and you can use it, then you use it. It will be more accurate for sure.
Right. I have the pentacam, but I'm not sure about your answer being always consistent. I can take three
this is
different
what this is what Dr. Mark Lobanoff has kind of said again and again, that the pentacam, the posterior corneal astigmatism from pentacam plays a role. And even Vavikar sir, Nitasha ma'am, all these people are also they advocate using the posterior corneal astigmatism. Rohit Shetty sir doesn't feel that it has too much of an impact. It may not have a very significant impact, but it will have, and in some cases it may have. Even my software will not be able to pick out those cases which have very abnormal PCAs. So pentacam would be more useful in those cases. Mine is a very standardized, under correction of with the rule and over correction against the rule.
Yeah, Vavi, if I can come across to you at this time, do you feel that, because I've not used the posterior corneal astigmatism so much because I use the Barrett nomogram for the IOL calculation. But do you feel when you look at various readings on the pentacam, the PCA is consistent amongst 3-4 readings?
Yeah, PCA is consistent. Not only that, PCA from IOL Master and PCA from IOL Master 700 and PCA from MS39 and PCA from pentacam, they also match with each other. They are fairly same. See what happens, one is giving you 0.27, other is giving you 0.29, third one is giving you 0.31.
Yeah,
so,
I agree, but the axis differs because I had spoken to Graham Barrett about it. He feels that since the Scheimpflug may probably not give you as accurate as what the the technology from the IOL Master 700 is.
see, that is we have had a discussion with Barrett. He said that Vavikar Saurabh tool, Tori tool is not that great because we are based on pentacam. But in practice, if you see, if you do Tori calculation on Barrett and our tool, the recommendation is same. Sometimes it is like, many times it is same axis on which you have to implant the lens. Sometimes there is a difference of 1 degree. That does not make any difference. So I think
I'm fine with a minor variation. I just, since you may be looking at 3-4, I don't look at them so consistently. But when you look at them, there's not a major difference, right? That's what you want to tell me.
Yes, it is. We can safely use pentacam. We can safely use IOL Master.
The value may be the same, but the axis doesn't go haywire.
No, there is not much difference. See, actually, I have a list of your cases only. I have taken 600 cases from your this.
I know. I had contributed to it.
Yeah. So it is very much predictable. And if you put the same values in Barrett, the astigmatism what you get on pentacam and on Barrett is almost same. There is not much difference.
Right.
We can safely.
So I would say that if you have access to it, you can put it, because that is what is the new things that are coming up, that they do play a role. But if not, then the next best thing is to use a nomogram correction, which I have done.
See, what I feel.
I hope your nomogram is as accurate as Barrett. You would have to measure these things at all.
No. I will tell you about Barrett nomogram. See, when it comes to WTR, everybody is fairly on target. When it comes to ATR, everybody is fairly on target, because ATR now the astigmatism anyway 0.22, 0.24. When it comes to oblique, everybody struggles. And
right.
In ATR also, out of 4, 1 case has some haywire astigmatism. In WTR, the Barrett like 96% accuracy. In ATR, it is 74% accuracy. In oblique, it is 53% accuracy. So we are getting residual astigmatism. If you are treating oblique cylinder, with whatever software. Whereas with ATR, because the magnitude is less, even if you are going, you are getting it wrong in 1 out of 4, the magnitude, whatever residual, is not significant, 0.25, 0.5. And with ATR, we are bang on target. With WTR, we are bang on target. So rather than going by a nomogram, it is better that you actually measured the value, put in the measured value and go ahead.
So just to add to that, I feel compared to toric IOLs, LASIK not having posterior cornea as accurate for LASIK is much more forgiving than for toric lenses, because one reason is most of the patients are with the rule who come for LASIK. So if you see an average, a nomogram works well, and even suppose you don't include it at all, it is much more forgiving, because there are a lot of other factors, variable factors, which are play here, which hide the inefficiency of not getting posterior cornea.
The best part, Zen, is that after LASIK, he still has the lens to adjust.
Exactly, right. So the lens compensation is a very big thing, sir. And that is the difference.
No compensation after pseudophakia.
That is the difference.
In fact, I measure the PCA like Bhavikar does in each and every case for IOL surgery. And once in a way, when I find a posterior cornea is 0.7 ATR or 0.6 ATR, it helps me to decide my toric model, because Barrett on an average considers about 0.3.
Right.
Correct.
Am I right, Bhavikar?
Yes, absolutely. You bang on target.
Anyways, coming back to this, so just to complete this case, the Contoura myopic overcorrection, which is C4, C12, the value is given over here, and you can choose whether to include or do not include. Sometimes I don't like to include it in the final correction for the simple reason that I like to slightly undercorrect my patients, in cases where it is very high. So I've given that option that if you want, you do not include it, or if you want, you can include it. And then this, I think you should always include the sphere nomogram adjustment, which is done automatically by the software. And once this is done, you go to primary sheet. And now over here, right down, you have your final treatment for Contoura. So this is the final treatment. You cannot modify this on the software, but if you have some changes, you can put it in this personal comments box here. So this was the first case example.
One slide backwards. No,
this one.
Yeah. Just show now how much difference does it make by choose from 13 it has become 0.27.
Yes, sir.
Okay, yeah.
If you do not include, and if you include, it becomes 0.27.
Now, but don't you think that keeping spherical equivalent makes a difference, and we should include it all cases? Why do
I feel like that, sir, but this is a very this is my very personalized preference that I feel I don't like to overcorrect the patients too much, even on refraction. I always tend to go little under correction. So ideally, in most normal cases, this value shouldn't make much of a difference. Anything which is so less, it has too much of unpredictability in terms of the temperature and humidity will affect the refraction more than what this value affects in normal cases. This is what I feel. I include it, but in some cases where it comes very high, like sometimes it may come to 0.4, 0. In those cases, I like to be little less, because I don't like to become over myopic. That is the reason why.
Fine, great.
But if you want, you can keep it on for all cases. That is fine.
Yeah.
Anyways, this is now the second case example. So you've got minus 4.5, minus 2.177, and cylinder is axis absolutely the same. Measure cylinder is slightly more, minus 2.65 at 177. Now the reason why I showed this case is because here the talus data is little, someone may get confused. It's looking like overall like a myopic kind of thing. How do you pick out the taluses? So you don't have to stress too much. What you feel, you can see the taluses, you just use those. I mean, so I feel here that this is one talus I can see right here. So this will be my one talus, and this will be second. And you can put in this one over here also. or you can just leave it. It's, so this, why I'm saying that so much of variability is allowed is because this is only going to give you a rough estimate into which direction your refraction is going to go. It doesn't have to always be accurate. Even if you're doing 4 CDs, there is a lot of variability in 4 CDs. Sometimes you can take the whole thing, sometimes you may not take the whole thing, you can break it up into smaller. So in this case, I've chosen these taluses and I've gone ahead. So, so in this particular case, I've entered the data. I go to right eye planning. I put in my taluses, my, sorry, this is not the same case. This is the case. Okay, I put in my taluses, software inbuilt nomogram, proceed. And we get all the values here. Topolizer, I'll see if the other topography is okay. I would prefer going with the topolizer. And here we see that now the final refraction that you've got, the cylinder value is coming pretty close to the measured cylinder and not going so much towards the manifest. The reason for this is pretty simple, because in this case, you've got ablation which is more vertically. So whenever you've got ablation which is more vertically, you are always going to undercorrect, and so the software will try to overcorrect that cylinder, exactly opposite to the previous case. So the point is that even if you don't understand this, all you need to understand is how to feed in the talus data. The software will take care of the rest. And in this case, it's giving you a final refraction cylinder which is close to the measured. So point is, when you use Alcon's protocol that you add 50% to the measured from the manifest, that doesn't make sense. You are just doing guesswork. You cannot accurately predict whether it's going to be there. Some cases you may have refraction close to the measured. Some cases you may have refraction close to the manifest. Some cases you may have refraction which is different from both. So you cannot just do that. And that is where the software, 4CDs and this software is going to have your back every time. You're going to, even if you may not get 100% result, you're going to be doing it scientifically. You're not going to be just guessing and doing. So that is the advantage. This is the last case I'm showing, which is one of the complex cases which I've done. The mixed astigmatism case. You see the refraction is +1, -1.75 at 90. Your measured is showing -0.43 at 2. And once I've kept the modified as 0, I've got my ablation showing 22 microns in the periphery and 10 in the center. Seniors on Nagvekar sir, Vavikar sir, any comments on this case?
This is very tricky. We need to think.
So that is exactly where my software does the thinking. And in this particular case, I'll show you how the software scientifically is doing this. Okay. So to understand this, I'll just show you that for the same patient, if we do a wavefront optimized treatment, meaning this patient was +1, -1.75 at 90, and with this the vision was improving to 6/9, and this is how the wavefront optimized profile looks like. Okay, so if I just go ahead and do wavefront optimized, I know from experience that if I correct so much, the patient will at least get 6/9 vision post surgery. I am sure all of us can agree, if we do wavefront optimized, the patient will get that much. So if you look at the wavefront optimized profile here, you've got 27 microns in the periphery and 11 microns in the center. Okay, this is clear?
Yes.
Now we go back to this case. I put in the taluses. The talus identification is very straightforward. We have one at 90 over here, and this one I would say is occupying 3 boxes, and this one would be in color zone 2, and yeah, 3 boxes, and it is at an angle of 75 degrees because the central point is somewhere here. Now I feed this data into the software. I go to right eye Contoura planning. I put in my talus data. Now in this patient, I had also got a pentacam done because of how irregular the cornea was. And so I put in the PCA magnitude and PCA steep axis. I'll show you how that affects. But right now, I'm just going to use the software inbuilt nomogram. and I'll press proceed. Now, in this case, it is telling you that the talus astigmatism is coming to 1.62 at 79, meaning out of 1.75 diopter at 90 degrees, 1.62 is coming from the talus. And you see the lens is also trying to compensate. There's fairly high lenticular astigmatism. And if you proceed and you get the final refraction, you see Alcon's recommendation is telling you Contoura LASIK is not recommended. And iSMART recommendation is telling you Contoura LASIK is best choice since high corneal order aberrations. You see the final modified refraction, the final cylinder is telling you to correct minus 0.3 at 124. And sphere has been reduced from 1 to 0.03. And you see the C4, C12 compensation here is almost 0.25. So in such a patient, I normally don't like to include so much C4, C12. So I may just decide to not include it. And this is the final refraction. From minus 1.75 90, you get minus 0.3 at 124. Now I'll prove it to you how this correction will actually correct the manifest cylinder as well as it will correct also the higher order aberrations. Because if you look at the ablation profile now if I have fed in my final refraction over here from my software plus 0.15 minus 0.3 at 124, what my software recommends, look at the ablation pattern. It is so similar to what you would have got with wavefront optimized, but only slightly irregular because it's correcting the higher order. So you have 23 microns over here, and you have 10 microns over here, and you have another, I would say, 20 microns, because this color constitutes around 20 microns. But because it is closer to the center, it will induce more amount of astigmatism. So if you compare this photo with your wavefront optimized photo, which is 27 and 11, you see how the ablation is being exactly in the same way as what your wavefront is. But it is slightly irregular because it is also correcting that corneal coma which is there. So you've got a similar ablation pattern and correcting the corneal coma with the software. Now, if I were to include the full manifest refraction over here, so if I would do the same without using my software, plus 1 with minus 1.75 at 90, you see here 39 microns is going over here, and this red zone is contributing to about 29 microns. And because it is closer, it will be even more. It will come to about 30. So wavefront optimized is removing 27 microns from the periphery. And if you do the same refraction with Contoura, you are going to remove 39 microns from the periphery. Means this patient will get very overcorrected. The cylinder will get very overcorrected. And if you use only the topography cylinder is minus 0.43 at 2. And you just do a spherical compensation, you see the ablation profile is totally different from what wavefront optimized is. So the aim of this software is to keep your profile as close as possible to the wavefront optimized profile, and at the same time also correct the refraction. So as Sonal ma'am was saying, if you would do this in a two-step procedure, in the first step, if you would correct the refraction as it is, you would first end up overcorrecting the cylinder, and in the second step, you would have to do a wavefront optimized to recorrect the cylinder. Because a large part of this cylinder is actually coming from your higher order aberration itself. And this proves that, for such cases, why the software is beneficial. And these sort of cases are best to do Contoura, because these are cases in which the higher order aberrations are very high. In these cases only, if you don't do, you will never understand what is the actual value of Contoura. So that is where the software plays a role, and that is how, that is how we do it. We assure that we can, get a proper result every time. So what I've already discussed, what is the benefit of this software? So if you do not use a software like this or 4CDs, Contoura can be done, because as I had said earlier, 50 to 60% cases, you will get a very good result. But you will, over a period of time, realize that wavefront optimized is also giving me good results, because Contoura, some cases don't do well, cases like this. But if you use the software in at least a certain proportion of patients, you will see that Contoura is giving you a better effect as compared to wavefront optimized. Not only that, even if you feel that it is not, you can at least be confident that you can do Contoura in all cases and do it in a scientific way without guesswork. So, that was all about my presentation. This is what I wanted to discuss and explain. Basically, I wanted to explain why my software actually should be used. ideally even 4CDs, but 4CDs is not available. And see, I have been using my software since a long time, but the reason why I've worked so much on it and tried to make it user friendly, because I really feel that there is need for others also to use it. Because when Alcon gives you the machine, Alcon doesn't tell you all these things, and these things are important.
Excellent presentation, Zain. Absolutely mind-blowing, eye-opening, and I'm looking forward to using it. Absolutely fantastic.
So have you tried it in KC cases?
I have done it in a few KC cases with this. See, the thing is, in keratoconus, we don't always look for correcting the total refraction, because we want to keep it as minimum. So I have not always used 100% of it, because it's always tissue sparing. But in that last case which I showed you, and similar such cases which are not KC but which have very high comas, and there are patients like that who have very high comas. If you don't do a software like this and you attempt Contoura, you will 100% need a 2-stage procedure, because you're not going to know only what refraction to correct. You can't do it just by guesswork. You need mathematics to get it. So that is I won't say keratoconus, it always works 100%, because see what happens in keratoconus, many times the anterior corneal topography given by the machine is highly overestimated. It may not actually be so much. So little bit of more understanding is needed when you're dealing with KC, but non-KC patients with high comas, it works very well.
KC patients, I prefer to just do, correct only the higher order aberrations.
Yeah, exactly.
So
so
more or less, it takes care of 50 microns, and you can't go more than that.
It does.
And I immediately do a sequential C3R after
that. But not only keratoconus, if you see cases of decentered ablation zones, for such patients, if you are doing a repeat correction, this software will be of great use, because again, in such cases, because the ablation zone is decentered, it leads to coma. And whenever there is coma, sometimes the cylinder on manifest, like in this case, if you see the manifest, the topography cylinder is not showing anything. It is just minus 0.4 at 2, and it is not a random cylinder. This cylinder exists. It's similar in pentacam also. So minus 0.4 at 2, if you're using, then it's totally different from what the manifest is. And just yes.
What was the autoref reading for the last patient after your LASIK surgery?
Autoref, I don't remember what the autoref reading was, but the patient
what was the patient outcome basically in terms
patient
of
was 6/5 unaided. Patient was 6/5 unaided.
Okay.
The patient was 6/5. In fact,
awesome.
Patient's both eyes were like that. Both the patient's eyes were similar. Left eye was not so much as compared to the right eye. And left eye was 6/6 pre-op. That was 6/5 post-op. And this right eye, which had a high coma, was 6/9, and it became 6/5 post-op. Meaning that low vision was because of the corneal coma. It was impairing the quality of vision.
Yeah. Okay.
Compared to this, then, whenever we had such cases where the topography cylinder was with the rule and the manifest cylinder was against the rule, it was largely attributed only to lenticular astigmatism. That was the popular teaching. But here, I think we need to look at the talus very carefully, because
in these cases, yes, so that's what I'm saying. You don't get many such cases, but if you do, then if you see like 20 microns in the periphery, that is very high, only because of higher order aberrations. And just to show you, in this case, if I just feed in the manual entry instead of the software algorithm and I press proceed, you see the refraction has not changed much at all. From 0.3, it's become 0.37 at 124. So answering the question about posterior cornea, this value is taken from pentacam. This PCA magnitude and axis is taken from pentacam. If I just put in my software as well, it's the same thing. It's instead of 0.3, it is 0.37. So that is not much difference.
Looking at those colors and the color zones that you have shown, Zain, it looks like only the the brighter colors seem to be important.
Yeah, exactly. Yeah. So that it's zone 1, zone 2, zone 3. These are the important ones. Rarely you have like, you know, a red color talus, which is in the center. But yeah, zone 1, zone 2, zone 3, these are the important ones, and the others are not so important.
Hi Zain, super presentation and understood much better than last time. I just had one query. In the last case, I mean, the Zerny case, I'm just curious, was it tallying with your, basically your talus astigmatism? Was it tallying with the Zernicke polynomial, the coma?
Of course it was. So Zernicke, see, you cannot incorporate the Zernickes into the final, you know, astigmatism, but it was, the magnitude was very high. It was like 1 point something, as far as I remember. It was very high. C7
Yeah.
and C8, they were very high. Yeah. They will be high only. They will be high. It's just a representation of that pictorial diagram.
Exactly. All
right. Should I stop sharing my screen, sir?
Yeah, as you wish.
It's gone on quite long. If there are any other questions, you know, I would be happy to answer them.
One question: when can I start using it?
So I hope the talus part has been understood well, and I've put the instruction manual as well. It's very simple. Whoever is interested, just email it to just send me this request, and I'll email it to you. It is based on Excel. So if you have Microsoft Excel on a Windows PC, you can use it. I've honestly not tried it on Mac, but I don't know how Excel works on Mac. But if you have it, then you can try it. And you have any doubts, you can ask me. I'll be happy to help, and I'll just give the software to everyone.
Excellent.
Great. Looking forward to use it.
Even there are people using 4CDs, Vavikar sir, Tanvi, Neeta Shah ma'am. I don't think she's here, but I would request you all also to use it and compare and see how it does with 4CDs, and you know, that would give me a lot of feedback.
Yes,
Okay.
But whatever you have done looks very impressive.
So since it's 10:30, shall we end now?
Yes.
Okay.
Yeah, I think it's okay.
Thank you so much, everyone, for ending. So I'm seeing some people have joined late.
Yeah.
Sir, I hope we have the recording this time. So
we have even last time's recording, by the way. I have.
But I think, forget last time's recording. This time it was much better, you know.
Much better.
Last time will be more confusing. Thanks to feedback from all of y'all, I could improve and, you know, do things better this time. So I'll definitely put this recording on the group. And whoever wants the software, just leave a request and I'll email it to you. Thank you everyone for attending. I hope it's been a fruitful 1.5 hour session. Thank you so much.
Fantastic session.
Thank you so much.
Thank you, Vavikar sir. Vavikar sir,
on behalf of the entire group, I am very thankful to you for making this presentation and opening our eyes to a new world.
Thank you. Thank you.
Look forward to using it.
And congratulations to the young engineers.
And to the engineers as well, Sahil and I forget her other name. Yeah. Thank you so much.
Thank you.
Bye everyone. Thank you.
Bye.
Bye.